everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's podcast episode is sponsored by SmartStep Surgical LLC. As a dedicated surgeon, you know that every day presents challenges, whether it's dealing with inefficient step stools or unreliable equipment that can jeopardize your safety and workflow in the operating room. Meet SurgiStep, the revolutionary motorized step stool designed to put comfort, safety, and efficiency back into your surgical practice. With effortless height adjustments and enhanced mobility, SurgiStep transforms your surgical experience while supporting exceptional ergonomics. One of the standout features of SurgiStep is their proprietary pedal containment system. This innovative design effectively eliminates workflow disruptions caused by pedals getting kicked off involuntarily, allowing you to focus solely on your patient. In addition to the step stool, SmartStep Surgical offers customized silicone mats which provide anti-slip and anti-fatigue properties to help you maintain your stamina and resilience throughout even the longest of procedures. So take the first step towards a safer, more efficient operating room. Use the link in the podcast to avail yourself of a 20% discount and set up a trial with them right now and revolutionize your surgical practice. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Welcome, Melanie. It's good to have you on today's episode.
Oh, thanks so much for having me. I've been a big fan for a long time.
Well, thank you. You're too kind. So let's get started. Melanie, I was wondering if you could give our listeners a little bit of background about yourself, where you grew up, where you trained, and then, what you've been doing kind of as an ENT surgeon for these last few years.
Okay. I grew up in a small town in Northwest Georgia. I went to Vanderbilt University undergrad, and I always knew I wanted to be a doctor. And so I did all the pre-med studies, all that good stuff, and all the lab work, all the things we all do to get into medical school. And then I went back to Georgia for medical school to go to Medical College of Georgia. And I thought I was going to be a pediatrician. In fact, I had my heart set on pediatric cardiology. We had a great pediatric cardio program. I loved kids. It was like the perfect thing. By the stars aligned perfectly, I was put on an ENT rotation. I had no interest at all in becoming a surgeon. My husband and I both actually agreed neither one of us would become surgeons because we knew we wanted a family and thought that lifestyle wouldn't fit. So we kind of made that agreement. I came home one day and went to the OR. Honestly, I didn't even know ENTs were surgeons. I'll be honest. I really thought they were just allergists. And first day of the rotation, the chief resident's pointing out who goes where, and he says, "Hey, you go to the OR." I'm like, "The OR, okay." And I walked into the OR, and they were doing it used to be called a commando procedure, which was a tongue, jaw, neck resection with the mandible filleted open. And I stared at that anatomy. I thought it was the most beautiful, amazing, perfect anatomy ever. And that piqued my interest. And within 3 weeks from there, I knew I wanted to be an ENT. My mentor, I was fortunate. I matched at the program. ENT was really competitive, and it was an early match at the time. And I matched into the ENT program at my institution, which was wonderful. We had this brand new chairman from Stanford. He was just a hot shot, really on the ball. And that was a really great opportunity for me. I did the breadth of ENT. And then as I was getting it to be, fourth and fifth year, my mentor pulled me aside, and he's an endocrine surgeon. And he really, offered me the opportunity to do a head and neck endocrine fellowship. And so that's what I did. And it was wonderful. He's a great mentor. And then I joined the faculty for a few years after that. After a few years in academic medicine, which I absolutely loved, my husband's career. He had a great opportunity to move to South Carolina, and I figured he had followed me around all these years, so it was my turn to do some following. So I went into practice here in South Carolina, where I did, probably 50% general ENT and then 50% endocrine. So still pretty high volume endocrine surgery.
Yeah. And this was in private practice now?
Yes, ma'am.
So I remember from our previous conversations, we've talked about the issue of ergonomics in surgery. I wanted to ask, how did you become interested in ergonomics? I mean, as a fellow endocrine surgeon, I mean, my story that, it was kind of relating to the pain and
Mhm.
symptoms that I was experiencing. So what started kind of your interest and then your journey into ergonomics?
Well, it's funny looking back, sometimes you look back on things and you say, why did I not recognize this? Even as a resident, I noticed I had pain along my rhomboids, and my husband every night or every few days, I would have him inject my back with lidocaine, just this one spot that was always bothering me from being like this all day. My mentor was doing a lot of endoscopic work, and we were doing robotic thyroidectomies, and we were doing all sorts of, crazy, wonderful things. But I started having pain even as a resident. But like every good surgeon, I didn't think anything about it. It's just part of the job and move on. During my 30s, I was having babies. I was busy. There was no time to think about myself. But as I approached 40, I decided, okay, it's time to take my life back. I had always been into working out, my husband too. And so when I was 39, I hired a personal trainer. I said, I'm getting back in the gym because I noticed my body was just aching at the end of an OR day. My back, my neck, my arms, everything ached. So that's when I realized it was time to get back, get back into the gym. And so I did really well, really within a few years of, a few months really of working out with a trainer. Noticed all the neck and back pain, everything just kind of went away. And it was wonderful. And so I continued a very active lifestyle, working out, lifting weights several times a week, doing, boot camps. I mean, just doing all sorts of fitness things. And then when I was 45, it kind of became a little bit, it was an insidious onset. I started noticing I was having trouble putting my white coat on my right arm. I just couldn't quite move it in all the right directions to put my coat on. And I would have to lean sideways. And my nurse practitioner, he would look at me and he was like, "What are you doing?" I'm like, "I don't know, I'm just putting my coat on." And I would lean these
Yeah.
weird. And then it began progressively hurting. And I noticed at the gym, I couldn't do as many push-ups as I used to do. So, like every busy doctor, I didn't make an appointment. I just pulled my buddy aside, who's an ortho surgeon in the OR next to me. And he, poked around and said, it's probably biceps tendonitis. Let's inject you with some steroids. So we did that. And, that would feel good for a few months. And then finally, I think the groundbreaking moment was it was a Saturday. I was on call. There was an airway emergency and was in the OR getting ready to trach somebody and, all the speed. And I went to grab the overhead light and I couldn't physically, my arm would not go in the air to grab the overhead light. And I kept kind of trying to do that and I could not grab it. And so eventually I took my left arm to raise my right arm to grab the light. And then I said, okay, now this is probably dangerous. I'm trying to take care of a patient. I can't do it. Maybe it's time to get that MRI. And so that started my journey of shoulder surgeries. I got an MRI. It said, maybe you have a torn labrum, some tendonitis, nothing really significant.
Hmm.
So I thought that was great news. But as a few weeks went by and I just noticed progressively I could not use that arm. So I said, okay, I have to have surgery. And
And this is your right arm,
this
correct?
is my right
Dominant arm.
arm,
Yeah.
my dominant arm. I'm a right-handed surgeon.
Mhm.
And I don't think I really didn't understand what it meant to have surgery. So I said, okay, we'll go. Let's fix this little torn labrum. No big deal. What's my downtime? And the ortho surgeon said, well, you're in a sling for 6 weeks. And I said, perfect. I'll block my schedule for 6 weeks. I've got surgeries scheduled. I'll just bump those people out a little bit. The day I come back, I could do what, 3 or 4 thyroidectomies the day I come back.
Spoken like a true surgeon.
Yeah. Yeah. And I literally told my surgery scheduler, hey, I'm going to have surgery Thursday. So
Mhm.
I did my morning clinic and I had a 2 o'clock OR for myself. So I did my morning clinic, saw those patients, told her, don't book any more scheduled surgeries for 6 weeks. I got to go have surgery on my arm in an hour. So I did my morning clinic and I went and had what was going to be a labrum repair. Of course, the orthopedic surgeon got in there and it wasn't just a labrum repair or tear. It was a super, rotator cuff, labrum, bicep. It was a little bit more involved. And so I had surgery to have, had it fixed. And I thought that would just be this straightforward path.
Hmm. Hmm.
I started my physical therapy, a week later, 2 weeks later, just like you're supposed to do. And I got frozen shoulder. So I was
Post surgery, right?
post-surgical frozen shoulder. I think, I was very aggressive with my physical therapy. I was going to physical therapy 3 days a week, which meant I was doing the exercises at home the other 4 days a week because I said, I am healthy. I am 45. I can do push-ups. I am a
Yeah.
rock star. And it might take the average person 6 weeks, but I'm going to be better in 4.
Everything's a competition with us, right? So,
Absolutely, absolutely. And I somehow thought I could make myself heal more quickly. 6 weeks came and went, and I still couldn't use my arm very well. And then we get to, the 8 week, 12 week mark, and my shoulder progressively worsened, my range of motion. I literally could not raise my arm enough to feed myself. I had to feed myself with my left hand
oh
because
my,
I was so frozen I could not, my husband was having to cut my steak, my chicken at dinner because I couldn't reach the table. So that's how my journey began. Eventually it took about I was out of work for 4 months.
hmm
I went back at 4 months, but I really wasn't normal till about the 10-month mark, living my
hmm
life. And so when I
hmm
got to the 10-month mark, I was doing all the things. I was still doing physical therapy. I started doing Pilates. I just wanted to do anything I could to improve, just to get back to normal. And so that started my journey with shoulder issues.
So, wow, that's quite, a lot that kind of happened. And like you said, in that sort of year, because we all have this expectation, and you had the same expectation. Okay, I have an injury, and then I'll get it repaired, and then this is what will follow, right? We have these expectations. What an adjustment of expectations was needed.
Mhm.
But it also kind of brings up another point, which is a theme in sort of our podcast. And I want to point that out to people who might be just, listening in for the first time and they happen to land on this episode, that, healthcare workers, and I include nurses, surgeons, anesthesiologists, but probably especially surgeons, right? We are privileged in a way that we have access to colleagues who can look at us, assess us, and things like that. And so we don't tend to initially go through the channels, if it were, go get an independent person to look at it, get some x-rays. We tend to kind of say, what can fix this quickly? And then just keep doing what we're doing. So, that seems like it was also part of your story. Now, I will say that I'm now intrigued about how in that year, that 10 months, did you, number one, get back to operating? And how does this injury then tie into what you learned about ergonomics? I think this is not the end of the story, so that's why I want to know more.
And so unfortunately, the story continues. Yes, you're very right though about us really not getting appropriate consultations. I was lying in pre-op doing push-ups to try to tell him where I was having pain, and I'm like, looking back, it was how stupid. I mean, I was trying to do a pre-op consultation.
It's okay.
And
I was guilty of the same. Okay.
oh,
Like I like you, I had a frozen shoulder post a fall at home. That was what
right,
precipitated kind of the long saga that was my jaw pain.
right.
But I didn't realize, I mean, I was hurting. It was classic. It was anterior capsulitis. And I was just like, oh, I can't get into my scrubs. You have to put your arm through. And I'm like, oh, maybe I can just rip the side. I made an incision on the side of my scrub to be able to put my arm through. So we pushed through. That's the word for it, I think, or the phrase for it.
It was a pretty traumatic surgery. Honestly, I just thought I would have surgery, and when I went to physical therapy, the physical therapist said, "You do realize you're not going to immediately when the sling comes off be normal." And I said, "What do you mean?" I mean, I
Right.
thought, so I didn't know there was all this strengthening and stuff. So I kind of had a little, I hate to use the word to be dramatic, but a little PTSD from that situation. It was fairly emotionally traumatic because I didn't realize it could take me that long to get back to normal. But I got back. I was working, busy practice, things in a great way. Things were wonderful. Got to where the pain was, really, it wasn't noticeable unless I did overstress my arm. So about less than a year later, my husband and I were out hiking and working out and we were on a trip on some little Caribbean island, and my left shoulder started kind of popping, not completely out of joint, but I could feel it subluxing. I knew something was happening with my left shoulder. I said, well, I'm just going to deal with this till it's unbearable because I will never have another shoulder surgery. I will not do it. I said, they can cut my arm off. I'm not having another rotator cuff surgery. So we get back to town and I went to a different orthopedic surgeon. And I will say, my first orthopedic surgeon was absolutely wonderful. I have not a
Mhm.
bad thing to say about him. I think I just had so much, I had not been prepared for what that first surgery
Right, right.
that I had another friend that was ortho and I went to see him about my left shoulder. I said, I think it's not staying in joint. Something's going on. And so we got an MRI and he said, hey, great news. It's a torn labrum. This is a piece of cake compared to what you went through with your right shoulder. He said, the cuff is totally fine. Melanie, this will be the easiest surgery, nothing like all the anchors you had to get in the right shoulder. So if you want to have an active life and you want to do the push-ups and you want to work out, then you should probably fix it. And I said, okay, well, let's fix it. You said it's easy. Let's fix it. So, like every good orthopedic surgeon, we go to surgery. It's supposed to be a simple outpatient patient surgery. And he comes into the recovery room, and I will never forget this as long as I live. And he casually says, oh, hey, by the way, it actually was your cuff too. It wasn't just the labrum. You have a torn cuff. And I said, what do you mean? You said 100% I didn't have a torn cuff. Like you told me 100%, not 99. You said 100% I don't have the torn cuff. And he said, yeah, MRI static images, it didn't look torn, but once I grabbed it, it was completely torn. Okay. He said, but this will be fine. This is fine. It was a simple, straightforward repair. Everything's going to be fine. And so I went with that. He said, stay out of work for 8 weeks. I said, perfect, no problem. I started physical therapy with this place that does all the athletes. I really was excited. My pain wasn't terrible. It wasn't as bad as it was with the first shoulder surgery. So I was really very optimistic. And so at 8 weeks, I went back to work. He said I could go back to work at 8 weeks, and I did. And I went back full schedule,
I see.
full clinic, full operative schedule, everything at post-op week 8. And some people may not know, as ENTs, a lot of our office work is arms in the air. We are
Mhm.
scoping everybody. I mean, if you come through my doors, you're getting a scope, which
Yeah.
I'm 5'4", which means my arms are above my shoulder if I have to scope you. So I started, when I went back to work, I started having a significant amount of discomfort in my shoulder. I just began icing my shoulder in between patients in the
And this
clinic.
was the recent post-op, so left shoulder.
So this was my left
Okay.
shoulder. A
Yeah.
year later when I was 46.
Mhm.
So I was icing my shoulder in between patients in the office. It was kind of a running joke. The nurses would change out my ice bags every 30 minutes, and I would just ice, and I'd see 3 patients and I would ice. But after about 3 or 4 months, I said to the surgeon, I said, I think something's wrong in my shoulder. It's
Mhm.
not, it doesn't feel right. He said, you're just still healing. You're still healing. I said, no, something is wrong. I don't have mobility. There's something in there. I can feel it. Like it's something trapped in there. So he kind of blew me off for a few months and he said, let's just get to the 6 month mark. And so we got to the 6 month mark. I'm usually, I'm pretty outspoken, but I just felt like I wasn't being heard. And so my husband actually went to the appointment with me and he said, I think you don't understand. I find her pacing our house at 2 in the morning crying because something is wrong with her shoulder. She can't sleep. The pain is unbearable. And I find her awake every night walking around the house in tears. So the guy says, okay, well, let's get the MRI. We get the MRI on my left shoulder, recently repaired rotator cuff. And the orthopedic surgeon calls me within 3 hours and he is frantic on the phone. He is very clearly devastated. And he said, I don't know, Melanie. It's completely ruined. The repair has failed. Your rotator cuff has retracted completely into the joint, which is what you felt trapping in there. I've never had this happen before, much less in a 46-year-old athletic, healthy female. I don't know what to do differently, and I don't know why it failed. So there we are. And so here, you go through all
Wow.
these things, and I said, gosh, I'm healthy. I don't have any of these risk factors other than being a middle-aged woman. Why have I had 2 rotator cuff repairs in a year and a half, and this one has failed immediately? So that was pretty devastating at the time. Pretty
Of
devastating.
of course. Understandable. How could it not be, right?
Mhm.
Wow. So now you had to sort of cancel your operating schedule again while you figured out what to do, or?
Not exactly. Not exactly. I didn't. I decided I would keep working as much as possible, But what I did is I decided I went on this mission to find an orthopedic surgeon that could tell me what was wrong with me.
I see.
So I went through every connective tissue disorder. I self-diagnosed I decided I must have all these terrible diseases. I went to 9 orthopedic surgeons. And, my question was, what are you going to do differently? This guy is a great surgeon. Why did this fail? Why is
Mhm.
this happening? And I went to academic centers. I went everywhere from Boston to West Palm Beach to Charleston, South Carolina to Georgia. I went everywhere just trying to get somebody to tell me an answer of what happened.
Mhm.
And then finally, I found through referrals a surgeon in Georgia who sat
Mhm.
down with me for over an hour and a half. And
Mhm.
he
Mhm.
went through my MRIs with me painstakingly and said, you have a very narrow joint space. It measures 2 millimeters. You cut immediately through the repair when you went back to work. He said, I can see exactly where you pinched the repair and you cut it. And it's retracted because it was a fresh repair. So
Did anyone in these journeys of seeking these specialized opinions, did anyone think that there was kind of an underlying disorder? I ask because, sometimes, as you said, you were looking for maybe it's a connective tissue to see, something like some variant of anatomy or something. Or it was basically, as you just said, this last sort of experienced surgeon sat down with you for an hour and a half and thought that it was, work related, going back to
yes,
work.
right. One of them entertained it. He said, Melanie, he said, we could chase that. Maybe you have a connective tissue disease of some sort. We could chase that till we're blue in the face. And he said,
Right,
if you want to, we can, but what will we do with that?
right.
And I said, well, that's a valid point.
Okay.
So that's where we were. And so when I finally met this surgeon who, I think saved my life in Georgia, who could explain to me, it was like it was almost felt like it was the first time an orthopedic surgeon really understood the demands of my job and took that into consideration. Because one
Hmm.
of the orthopedic surgeons even said to me, he said, aren't you like a dentist? Don't you just lay everybody down and work in their mouth? You don't even really use your arms, do you? I was like, oh my God. No, my arms
Wow.
are above my shoulders most of the day. It was like somebody who actually understood what I do for a living and could explain the injuries.
Hmm.
And that was a game changer for me.
Right. Now, this surgeon from Georgia, did they think that your previous right shoulder injury was also work related, like the repeated work that you were
He
doing?
did. He
Yeah.
absolutely did. The unfortunate thing is in the process of going through all these consultations to see why my left shoulder failed, I retore the right rotator cuff as well.
Oh my goodness.
So as I'm going through trying to figure out how to repair this left one, I was overusing the right one because I
Right.
did not stay out of work like I should have. I went
Right.
back to work. So now my right arm had to do the entire job and I retore the right rotator cuff. So now I'm sitting here with a completely destroyed left rotator cuff and a 75% tear in my right rotator cuff simultaneously. That's why it's a saga.
Right. No, I can completely appreciate that from what you're saying. And I think it sounds like when you got to this point, then did anyone offer or did you decide then to have another repair of both, or like where did that land up? And then did
Yeah.
you end up
I
did you
had
end up going back to work or could not?
That was my plan, was to go back to work. And the surgeon I found in Georgia who was so wonderful, he said, I said, I can't live like this. This left one, I have the
Mhm.
impingement. I mean, my arm couldn't even make a circle because there was this
Right.
impingement. And so I told him, I said, I can't live like this.
Hmm.
It's unbearable. And so he said, okay, Melanie, what we'll do is we'll fix your left one. We'll let that heal for 3 months. You will fix the right one. You'll be out of work 6, maybe 9 months, and you can go back to work. And then the left shoulder surgery was it was pretty intense. He had to use a cadaveric tendon. There, I'd completely destroyed, the repair. I just read the op note today and just took me right back. But it's what they call a supracapsular reconstruction, which is when a rotator cuff is no longer repairable, can be repaired. They use cadaveric tissue. So I had that surgery done on the left, and it honestly changed my life. And while he had me asleep, he positioned my arm in a lot of different positions, and he said he could see 100% why I cut through the original repair. My
Hmm.
acromion process was elongated. He said I had the perfect storm of a very long acromion process and a narrow
Hmm.
joint space, and the unfortunate thing of having a job where I lift my arms above my
Lift
shoulders
your
all
arm.
day.
Yeah. Yeah.
And he said there's really like people can walk around with all of those things separately, but the unfortunate fact that I have all three of those things was just really the straw that broke the camel's back.
And then just to kind of bring it full circle for our listeners, after these like, re-repairs of the
Mhm.
shoulder, cadaveric, etc., are you now, obviously I'm glad to hear that your pain is better, but are you back to work or did you go back to work?
I really wanted to, and I went with my orthopedic surgeon. He kept saying, "Let's give it 3 more months. Let's give it 3 more months. The repair's
Sure.
not where I want it yet." And then just about 9 months ago, he told me that in good faith, he could not suggest I return to work, and he recommended retirement.
Wow, because you couldn't do the very demands of the job without a risk of re-injuring
Correct.
yourself.
Yeah, he said the cadaveric tendon, we don't know the lifespan of a cadaveric tendon anyway. And he said, but I can promise you, if you go back to lifting your arms all day, you will cut through it. It's a matter of when. So
Wow, that's a lot. So now, for our listeners, Dr. Seybt is retired from clinical practice, but she's still kind of working in her private practice in a different role, and I'll let her expand on that. But I just want to highlight a couple of things that jumped out at me during this last little bit, of the conversation. One thing that jumped out at me right away is that, we are now seeing literature on this, but we have known this all along. Sometimes women's health concerns are not taken seriously. And
absolutely.
yeah, and I want our listeners to realize that it doesn't change if you're a physician, because not to the same extent as you, Melanie, but when I was going through the worst of my pain, because it was in the jaw and
Mhm.
the neck was secondary, although in retrospect, the neck was primary, and that's why my jaw was hurting. So I was sent to jaw people, jaw physical therapists, oral surgeons, this and that. And at least on two occasions, I got the impression that people thought it was all in my head
Absolutely.
because there was nothing anatomically wrong with my jaw,
Mhm.
and I had like a bulging disc in my neck, but it was bulging on the opposite side of my jaw pain. So I just wanted to make that clear that through sheer persistence, you were able to arrive at an answer that made sense biologically, physiologically, and it took me some time and self-sleuthing to
Yes,
figure out and then kind of go back and then try to kind of see what the ergonomic contribution was and things like that. So I guess advice to people overall would be whether you're male or female and whether you know 10,000 different specialists, it's always good to start some sort of investigation early, report it to your physician so that there is a paper trail, right?
absolutely.
Because our injuries are chronic wear and tear, right? They're not this, acute where you can fall and then say, okay, I fell and that's why this happened, right? So
Right.
there's that. So always get that. And then people who are providing care to us, keep in mind that even women physicians feel, are faced with kind of unconscious bias,
Absolutely.
similar to women in the general population, and just allow yourself to step back and ask, am I coming at this place from or am I coming at this situation from a place of unconscious bias? And we will be right back after this short message. If you're a surgeon or proceduralist finishing your OR days with neck pain, back pain, hand symptoms, or just feeling physically drained, I want you to know something important. These problems may be common, but they're not inevitable. Most of us were trained how to operate, but we were never taught how to operate for decades without accumulating preventable strain or reducing the risk for a career-ending injury. That's why I created the Surgeon and Proceduralist Career Longevity Program, a fully virtual hybrid program that combines small group learning with individualized ergonomic analyses using your own work videos, AI motion capture software, and surgeon-specific recommendations. Just to be clear, this isn't generic ergonomic advice. It's a personalized approach designed around your body, your specialty, and how you actually do your work. If you want to keep operating at a high level without sacrificing your body in the process, sorry, just edit out this last section. I'm going to record it again. If you want to keep performing at a high level without sacrificing your body in the process, or are looking to return to the OR after recovering from a minor or major injury, Reach out to me at geeta@surgicalergonomics.com to learn more. And now back to the episode. So that was the one thing I wanted to talk about. And then the second thing I wanted to talk about is that, there is always a component of nature and nurture, right? As we were talking before we started to get into this conversation. If your joint space hadn't been narrower and if you hadn't had that longer acromion, whether it was from degenerative disease or whether it was, you know, perhaps things wouldn't have gotten so compounded. But how are you to know that? And I had my first disc herniation at 24.
Crazy, right?
I didn't know that there was probably a genetic predisposition, and my job didn't make it any easier, right? That knowledge came much later in my late 40s and early 50s as I figured these things out.
Right.
And in keeping with that, I also want to say part of this nature nurture discussion, and perhaps you can weigh in on whether this came up in any of your multiple kind of opinions and consultations. I have heard and I have read about the high rate of injury, musculoskeletal injury among ENT surgeons. They're on par with endocrine surgery and ENT. I mean, we did that combined survey, right, of AES and AHNS members. 95% reported pain from operating. And if 95% are reporting it, that number is higher, right?
It's 99. It's
Yeah, it's
99%.
99, right? 99.9%. And exactly the things that you pointed out, women surgeons are far more likely to experience symptoms, myself included, because again, many factors, right? We happen to be shorter, we happen to have, less upper body strength, generally speaking, not
Right.
generalizing. And then our instrumentation is not designed for our hands and all these things, right? Again, a combination of nature and nurture. But I think there's another element that has come to light as I've studied sort of ergonomics in different surgical fields, is that there is this distinct rise around middle age of injuries and especially frozen shoulder for women,
Absolutely.
which has to do with hormonal fluctuations,
Absolutely.
as I discovered in my own case, as well as your case, and many, many other women surgeons that I now, see with injuries. And we're going to air an episode of the podcast in the coming weeks with an exercise physiologist. And this came to light even there, like, the athletes, they often have their training regimens designed around their kind of cycles, uh,
Uh,
hormonal phases, because there's some real risk of kind of when you can train well and when you're at higher risk of injury and things like that. So I just wanted to point these things out. Maybe they apply to people who are listening to us, maybe they don't. But when these things start to converge, please get yourself to someone who can do an evaluation.
Absolutely. Absolutely. Everything you say is so true. And I think, hindsight, of course, is 2020.
Of
Um,
course, yeah.
And at 5'4", it's what I had always done, right? You just scope people,
Right.
you just do the surgery, you do all the things. But now I know, gosh, if I had had a step when I was scoping people and my arms were not above all my shoulder the entire day, maybe that would be better. We used to double stack the lifts in the OR so
Yes,
that I could get
yes.
high enough, and sometimes even double stacking it was still a struggle. So, I would say, and for me included, I think sometimes women, we want to be respected and treated like the men. And so we don't want to be high maintenance complainers, right?
Right.
So I was never going to be the one to say, give me a third lift, or, we've got to come up with a better solution, because I just wasn't going to be a complainer. Ultimately, we pay the price for that with our bodies.
Right, right. No, I think I agree with that statement as well. And that has come up on this podcast too, because some of us, I mean, we're of a similar generation, and some of us were the first in our programs for various things, and you were out to prove yourself. And
Absolutely.
so you worked doubly hard and you complained, less than 10% of the time that somebody else might complain, so
Right.
yeah.
Absolutely.
So you started to share, like you said, I wish I had known. And this sort of knowledge and wisdom is coming to us in hindsight, like you said. But we can do maybe things a little bit differently so that maybe future generations don't have to do it this way and face, these kind of consequences. And that's why, I'm really appreciative that you're here today, among many other reasons. But this is, for being, it is not easy. And I can see how hard this journey has been for you on your face as well as on listening, to you speak. And I want to just say that I acknowledge your strength and vulnerability at the same time in being willing to share this with our listeners so that somebody can learn from this. So thank you.
Thank you for that. It has definitely been a journey. There has been a lot of grief because I absolutely loved being an
Right.
ENT. Love my job. So there was definitely a grieving process. And we go, we talk about it's so much of it is our identity. I mean,
Exactly.
I joined a program that was all dudes and I wanted to be one of the best. And, when I came to town, I was the one people called when they got into trouble, you know,
Right.
not just my department, other departments. And so that was kind of a badge of honor for me to be like, oh,
Yeah. Yeah.
she's really good at this. And so to have that taken away against my will was a very challenging time in my life.
I can appreciate that, as I said in our conversation, as well as, our previous kind of communications about this.
Mhm.
So, I guess in that note, let me ask you, you mentioned a couple of things, the wish you had a stool or, stability in terms of stools, etc. So, what do you think we could do better? And by that, I mean, how do we train our residents? What would be the tips and advice that you would give them, based on your experience, not just about what they can do in the OR, but what they can do outside the OR. But then moving from one-to-one sort of trainee education, what about sort of incorporating things in curricula for the residents, for the junior faculty, for fellows, doing subspecialty training? And then, how do our professional societies and things, play into this? And do you see some progress being made in this regard in your specialty?
Um, to be honest, not really in my specialty, which was a little disappointing. I was really excited. I was at a conference maybe 9 months ago, and
Mhm.
there was a lecture that I was so excited. Somebody had something about surgical ergonomics on the schedule, and it was just kind of a brief lecture about some cervical pain. But I would say it's not really well known, and I think even if we had grand rounds lectures where we are talking to the residents about these things they need to do to take care of their bodies. I mean, athletes take care of their bodies, but we
Right.
don't. Why do we not have somebody that can do chair massages in between cases, for 15
Right.
minutes to stretch your back and shoulders? There are things that could be done to help, but then also I know a lot of people, if you say, okay, you need to get a massage once every 2 weeks and you need to work out 3 days a week, and a lot of people feel like there isn't time. They feel stressed that there isn't time.
Absolutely. Yeah.
But what I will say is if you don't make that time when you're young and healthy, your career will be shortened most likely. So we kind of need to start treating our bodies like athletes do.
Right. Right. No, you made a very good point there. And I think that was one of the reasons or my motivation for starting this podcast was that we were giving grand rounds, like members of the Society of Surgical
Mhm.
Ergonomics, myself. We're getting to various conferences, where they have like a 20-minute talk, like three panelists,
Right.
and I felt like that was a great introduction, but you barely were able to touch sort of like, okay, this is the risk factor, this is what happens, what are the potential
Right.
consequences, and then here are the things you can do. But then, like you said, the key thing is people in healthcare are drowning. Okay, everyone is in survival
Absolutely.
mode. And saying you need to do something, even if it is for their own good, is just not, I found the messages aren't landing, right?
It's
Because
just
people,
another thing on the
yeah,
checklist.
exactly, right? Right. When we add to things that they need to do, that's not landing, right? So we have to figure out a way to make it so that it's part of the workflow, right?
Right.
Yes, a basic set of knowledge is needed, but then it's, got to be incorporated into the workflow. And so that was the impetus. One of the other reasons for having this podcast, other than to have people share their stories, is to be able to kind of have an individual episode, maybe just talking about how you position things for the OR, and another episode talking about what a physical therapist can do for you, and another episode talking about what a massage therapist can do for you, and things like
Right.
that.
Right.
Now, Melanie, you've been through a long journey, and most people keep functioning kind of in their pain, but Some, like you, have to retire early because of a career-ending injury or the risk is too high of re-injury, like you stated. And the disability process is kind of a black box. For our listeners, we actually have an episode from early on in the podcast. It's with Dr. Stephanie Pearson.
She's wonderful.
She started her own insurance firm,
Right.
Pearson Rabbits. So, but I kind of want to hear also from your perspective, or I would like to hear from your perspective, what were some of the things that you learned during this process of multiple surgeries, multiple injuries, and then eventually needing to retire and be on medical disability?
Mhm.
Some good things, the bad things, and the ugly, advice that you could give to sort of trainees looking at purchasing disability insurance.
Absolutely, absolutely. A couple of things I can say about that. One is I never dreamed I would need a disability policy. I was, like I said, avid
Healthy.
working out,
Yeah.
Spartan races, all the things. And our financial advisor really just talked me into it in my 30s. He said, I know it's expensive. Everybody says, oh, it's expensive. You're going to spend three, four, $5,000 a year. Thank goodness I did that because otherwise, I mean, I have partners that don't have private disability policies, and if they had a career-ending injury, they would be out of luck. So thank goodness I had a private disability policy. The disability process was a little intimidating for me in the beginning because sometimes some of these people that call, not sometimes, a lot of times these people that call from the disability insurance companies can be a little abrupt and rude and haven't read the entire file and don't really even know what you've been through. So it was a little intimidating, but if you can have a good agent that really walks you through the process and can support you to help you know exactly what documentation you need, it is incredibly helpful. I think every person, when you finish training, you need to get a private policy. I had a very good private policy. And in fact, they went back and looked and said, wow, you've actually lost quite a bit of income since your first surgery. We
Mm,
feel like we owe you more money because of the lost income from the time of your first surgery 2 years ago. So they sent me money for that. So it's been a really a good blessing to have
right.
that. But documentation is the key. Sometimes surgeons are not great communicators. So even helping my orthopedic surgeon know, like, please be very clear about my limitations and the risks of me working. And so when I said to him, I'm not telling you what to say. I'm just saying I need you to be very clear about what my limitations are and what the risk is if I return to work. And so spelling those things out, 3 sentences, is very helpful in the disability process.
Mhm. Now, I'm glad you mentioned private disability, and I assume yours was own occupation as it should be, right?
Absolutely.
Right?
Absolutely.
Because if you can do something else, then if you don't have an own occupation writer, they're not gonna pay, right? So you
Mhm.
need to have the fact that if you can't work as a surgeon, then you're
Mhm.
eligible for payment. So I have to ask, did you have an institutional or an employer-based disability policy as well, or no?
I
And
did, yeah. But it had a 2-year benefit.
yeah, they're usually limited in scope or time.
Yes.
So yeah.
And plus those are taxed, right? So
Correct.
the
Correct.
money getting paid for a disability policy that then you're paying
Income
48%
tax. Yeah,
your
yeah.
income tax on versus the if you have a private policy that is not taxed. So that ends up being quite a bit more beneficial. So I tell people all the time, you have to have a private policy. You think you will never use it, and you pray you never use it. But in the event you need it, it's really a game changer.
Great advice, I should say, not just good advice, but great advice for anyone, looking to purchase insurance. And by the way, the best time to get it is before you get any injuries.
Uh,
So the soonest you can afford it in training, they have cheaper rates for residents, and then they usually adjust for income as time goes on. So this is one of those things that really is a non-negotiable. If you're going to have a career as a surgeon or any other high-paying career, you need to absolutely do this. So if you want additional information on this, obviously, listeners, please go back to that episode with Dr. Pearson, and I'll make sure to link it in the show notes here as well.
One other thing I will say about that is I had a misunderstanding about disability insurance. I thought it had to be a situation, Steph, like Dr. Pearson's, where you were acutely injured in a, like, boom, you had your shoulder broken.
I see.
That's not actually the case. If you have an injury in your daily life that prevents you from doing your job, your disability insurance will still cover that. So I really had a misunderstanding about what qualifies you to get, disability insurance or get the disability claim. It doesn't have to be just something that happened at work. It's anything that happens in your life that prevents you from being able to do your job.
I know a surgeon who injured their shoulder badly downhill skiing and then couldn't operate. So, okay. Well, Melanie, we're almost to the end of our time that we set aside today. And I just want to again reiterate and thank you very much for being a guest on today's episode and sharing your experience with us. And I should say, sharing your experience with me as well as all our listeners. I know it was painful, in the literal and the figurative sense, relive that journey, but I'm sure that people listening will take notice, and if it can help them, then well worth it.
So thank you for that. I will tell you, I don't necessarily like telling my story, and I don't know that I've ever told the whole saga because it is such a saga in one sitting. The reason I said I would tell this story, I don't like telling it because I feel like I'm whining and complaining because
Not at
I don't.
all.
But the thing that gave me hope is when I was going through that third tear and I was devastated and I thought my life was ruined and I thought I was going to live in pain for the rest of my life. I read an article by Julie Way, who
Yes.
is a pediatric ENT, and she talked about an injury she had to her shoulder and how she was having difficulty working. And I didn't know her at all at the time. I just read it in one of my ENT bulletins. And I looked her up on LinkedIn and I sent her a message and I said, "Hey, I read your article," and I started bawling because I didn't think there was anybody out there that had been through anything like I have been through. And I just want to say thank you for writing that article. And then she connected me with you, and the rest is history. So I do think it's important, even though we don't like to complain and whine, it's important to let people know that you're not alone. And
Right.
there are many of us strong, amazing surgeons that have gone through some really bad things, and don't keep torturing yourself.
Right. That's exactly it. Well stated, Melanie. There's so much shame and stigma attached, and it's
Absolutely.
and pain, chronic pain is so isolating, right? And we think that nobody else is going through it, and this is how we can start to break that cycle. And that's why, as I said, I am very grateful that you were here today to share your story. Thank you.
Well, I'm grateful that you're doing this, so thank you.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.